Right, good evening, ladies and gentlemen. Welcome to this evening's 21 for 2021. I'm delighted to welcome our Director of Regional Affairs, who is Pippa Dolman. And Pippa is going to be talking to us about silicosis. And her webinar is entitled Silicosis, Is It the Next Asbestos? And I believe that this is number 20 in the series of 2021. I think we're going to end up doing either 22 or 23. It was buy 21, get 2 free. I'm delighted to welcome Pip. I'm not going to speak for any longer than necessary. So over to you, Pip. Thank you very much.
Thank you. Well, thank you all for joining and welcome. Please do put any questions in the chat as we're going along, and I will endeavour to answer them. If it's burning, just please say urgent one, then I'll answer it straight away. But otherwise, as Neil says, there is time at the end for questions. So today what I want to do is talk to you about me, first of all, and then about silicosis. So my role currently, I'm the Clinical Performance Manager for the South NHS team at TP Health Limited, which was Team Prevent, but we rebranded in April. I'm also, as Neil says, the Director for Regional Affairs for IOH, and I'm a CQOS assessor. I've previously worked as an occupational health manager, and my last job was B&CE, and in that job I was involved in developing standards for occupational health and construction, and that's really where this piece of work about silicosis came from. And I have over 20 years experience in occupational health, and it's actually 30 years this year that I started my nurse training, and I feel very old. So in terms of RCS, what is it and what's the silicosis link? So respirable crystalline silica, which is a bit of a mouthful, so we all say RCS. It's essentially silicon dioxide, which is a naturally occurring mineral that's found in rock, stone and sand. It is naturally occurring, also including quartz. There's lots of other different things it's in, and it's most dangerous when it's freshly fractured. So the thing to bear in mind with it is when you're walking along the beach, and you see my lovely background of the beach I was on 2 weeks ago in Fuerteventura, walking along that beach is not dangerous to your lungs because that is not fractured. When we say freshly fractured, we essentially mean cutting it or sandblasting it or doing something to it that actually disrupts its essential structure and turns it into crystals. Where you can find it, you can find it in bricks. That's quite an obvious one. Bricks and cement, so that's there. And if you're cutting into bricks, or if you're taking cement off bricks, if you're clearing up to do some DIY, or if in demolition, if people are on building sites, you can come across some RCS there. Also in pebbles and stones, if they're being cut, so stoneworking, so people doing dry stone walls and actually chipping the stones to break them to the right shape potentially, or also sandblasting and cleaning up some old buildings. Cement paving slabs, so that's more of an engineered one where they're actually made into that shape. The most common one that causes a problem these days, to be honest now, particularly in Australia, is these lovely engineered stone worktops, things like your travertine worktops that are beautiful, but they're actually very dangerous. So those are some of the things that we can find it in. In terms of the particle, what respirable means is that it's a particle that's small enough to get right down into the alveoli in the lungs, so right down at the bottom. They're about 4 micrometers in size, and that credit from the HSE, that little picture of a penny and how big the silica dust is, gives you some sort of idea of how tiny these little particles are, and the damage that they can do is very significant given how tiny they are. So in terms of your health problems, it causes silicosis, hence the name, which is a fibrosis. It's one of the fibrosing lung diseases. It can be acute, chronic or accelerated, and I'll explain a little bit more about those in a moment. Also associated with silicosis is renal disease, scleroderma, systemic lupus erythematosus, TB and lung cancer, all associated with these little tiny particles. In terms of the pathology refresher, and it is a very quick one, I don't claim to be a path expert. As I said, it's a long time ago since I did any serious research and reading in pathology. But silicosis is fibrosis, which is scarring and inflammation in the lungs. It's a form of interstitial lung disease, and the particles settle deep into the lungs. And what they basically do is they create little pockets within the lungs, and the lungs try to get rid of them. And in the process of doing that, they actually damage themselves and cause the scarring. So you've got the main three types of silicosis. You've got acute, which is a very rare form of it, life-threatening condition, and it's significant exposures in very short period of time. And what happens there is the lungs do start to fill up with fluid, so you get shortness of breath, cough, weight loss and fatigue. Accelerated silicosis develops within a few years of, again, very high exposures, and that's associated with the autoimmune conditions and the renal conditions such as SLE. And the chronic simple one is the one everybody thinks is the most common, and it is. However, we're getting more issues with the acute and the accelerated, particularly with the engineered stone worktops. The chronic simple one takes about 10 years at least to develop, doesn't generally impact your life expectancy, but it can cause some heart failure, which then can lead to premature death. But generally, it's more about quality of life rather than actually shortening your life. One of the other things it can cause, which again seems to be becoming more common, particularly again with the engineered stone worktop workers, is progressive massive fibrosis. And essentially what that happens is you get these big areas of conglomerate masses where the little holes in the masses in the lungs are actually greater than 1 centimetre in diameter. They start to get bigger and bigger, and therefore obviously you get the associated problems you would expect from that when you have issues with your lungs. In terms of your current legislation, it comes under COSH 2002 and the ACOP for COSH L5, which came out the last edition in 6th edition in 2013. There is a workplace exposure limit in the EH40 workplace book. It's 0.1 milligram per metre cubed per 8-hour time-weighted average day. In terms of the health surveillance requirements from the HSE at the moment, it's an annual questionnaire, annual spirometry, ideally before you start working with RCS, a baseline chest x-ray, but it's rarely to be often, doesn't often happen. And then ideally after 15 years of exposure, you've got 3 yearly chest x-rays. We'll talk more in a moment about what that means and is that accurate. To the right of my slide there, you've got a little bit of information about the hierarchy of control for health and safety. And it's not about PPE and masks. It's more about eliminating things, removing the cause of the danger completely. So actually doing things that actually help the person to work safely by not exposing them in the first place, rather than looking at how you can protect them by giving them a mask. So it's really about choosing what's the best control measure because it works better, not because it's easy and fast to implement. We know from watching people walk around our supermarkets over the last 18 months, people don't like wearing masks and they don't know how to wear them properly. And that's a little indication of what happens across the board with people. If you ever go onto a site, or like me, you watch the road workers and the chap who's on the Kangoo digging up the road has got his ear defenders and his mask on. People standing next to him watching have got nothing. People don't wear PPE, so it's better to have something else that actually helps them. So it starts off with the best thing to do is eliminate it and working up through the pyramid there. Some key dates about asbestos. When I started working with B&C and we started looking at asbestos and silica, I found a wonderful book and I got very excited, and people who know me well will know I'm a real nerd when it comes to things like really good research bits of information and really old documents. We found out actually that silica was identified as causing problems in metal miners way back in 400 BC by Hippocrates, father of medicine. You compare that to asbestos, we didn't really realise it was a problem until 100 AD, and that was Pliny the Younger, so still going back a long time. And these two things are still killing people day in, day out in this country and all around the world. From a silica perspective, there's a few interesting things that happen. And if you look at the dates on the left, most of them, up until about 1870, the silicosis things were happening in the background. And then everything stopped. We seem to focus more on asbestos, and we've come a little bit more towards silicosis now, and we're getting there, but it's still actually not very well documented, well managed, and certainly not well looked after from the perspective of surveillance and prevention. Looking at one of the interesting things I found out when I was doing my research was 1713 was the very first patent granted for grinding flints by a wet method. So essentially water suppression when you're cutting. And that's probably the first patent granted for a control measure in health and safety back in 1713, which I think is really very nerdy about history. I think that's fabulous. Ramazzini, father of occupational medicine, he identified a connection between asthma-like symptoms and sandy substances in stonemasons' lungs, again in 1713, a long time ago. They knew that was a problem then from the sand. They knew what was causing it. In 1780, there was a big report which said it was rare for stonemasons to live symptom-free to the age of 50. So again, we knew there was a problem with the stonemasons cutting. And in 1870, Visconti coined the term silicosis. He actually linked the silica from the sand with the problem that was happening in the lungs. There's then a huge jump over 120 years up to the IRAC classifying silica as a group 1 carcinogen. And that essentially means they recognised that there was sufficient evidence to say that silica definitely causes lung cancer in humans. There's different classifications of the IARC, and group 1 is it's humans and there's evidence for it. But we didn't get our first workplace exposure level until 2002. And that didn't change till 2006, and it's remained at the level of 2006.1 milligrams per meters cubed since 2006. I was really pleased when I was doing my B&CE work to find in 2020, very early in 2020, and after the Brexit debate, that the UK government did actually enact the EU Directive 2004/37/EC. And what that basically is the directive that recognises RCS as a causative agent in lung cancer when it's created by work processes. So that's a really important thing to have done. And I was slightly concerned that they wouldn't take it on board because we were going out of the EU. We'd have said, actually, do you know what, we don't have to, we're going to ignore it. And that will hopefully lead to better protection for people in the future. From the asbestos perspective, you've got circa 100 AD, as I said, Pliny the Younger, recognising that asbestos causes problems. And then nothing really happened with asbestos either until 1899. And that's when Dr. Murray wrote in the BMJ about health effects of asbestos causing some problems. In 1927, we looked at fibrosis in the lungs of a textile worker, Nellie Kershaw. She was the first woman who died from asbestosis, and it was recognised then. And from then on with asbestos, in a complete difference for silicosis, you think 1870, we knew that we had silicosis. 1927, we've got asbestosis. But since 1927, we've had a raft of different regulations for asbestos, and we've had nothing really that significant for silicosis. We've got a few directives and a workplace exposure limit, but we haven't had the control of silica at work regulations, which potentially is where we need to go. And so that's the difference between it. But as I say, we've known about these problems for an awfully long time, and we're still killing people. Going on to the work I did with B&CE, when I was there, I was fortunate enough to get involved with the Respiratory all-party parliamentary group, and we did an investigation into silicosis, which is where a lot of this knowledge came from. And an APPG, for those of you like me who aren't really very up on politics, they are cross-party informal groups within Parliament. Any member of Parliament or MP can join a particular group. They can join as many as they like or as few as they like. And they're very unofficial in terms of status. They're really about people getting together to talk about a problem and try and do something, but they don't have a lot of clout. That said, they can lead to different changes in work if there's sufficient push behind them, and they have been known to actually change the law. And this particular APPG is the Respiratory Group, and it's chaired by Jim Shannon, MP for Strangford rather, over in Northern Ireland. And why undertake it? Well, working in construction, we know, and this is one of my favourite stats in construction, you're 100 times more likely to die from a preventable work-related condition than you are from an accident at work. And that's quite scary when you think about how many people die in accidents at work, every year in this country. There's an awful lot of them. The HSE stats tell us around 12,000 people per year in the UK die because of exposure to dust and fumes at work. Parliament hasn't done anything about this for many, many years. The last, you're looking at COSH not updated since 2002, and most of the dust and fume exposures fall under the COSH regs. So there's an awful lot of information there that potentially we can tap into about these are the people that we're exposing, and we haven't done anything for it. Also, at the beginning of 2020 and since 2018, there's been a push and a notice really in particularly Australia that there are an awful lot of increasing cases of silicosis in a younger cohort with much shorter exposure levels, 3 or 4 years rather than 15 to 20 years. And those young men and young women were dying. And that really led to it. Is this going to happen in the UK? And I think the reality is, unless we do something pretty quickly, it's going to. So our inquiry actually found that we looked at some of the key themes, we looked at the scale of the problem, we found it was unknown. We knew that really anyway, but everybody was telling us, from the unions to the construction companies to the health people, the health and safety people, everybody's saying, we don't know how big this problem is. We have no national silicosis register. We don't even know how many people work with RCS. There's a lack of understanding and awareness in the risks. You only have to walk around, your average town centre where people are doing some work on their houses to watch your local builder's firm not wearing any form of PPE at all, never mind thinking about what, cutting with wet suppression or actually doing anything about what their exposures are and working in different ways. We also found significant clinical difficulties in identifying the disease. Several of the group of occupational respiratory disease physicians presented evidence to us, and they actually said, when we get something in from GPs, they don't get a decent occupational history. Nobody really knows what people are exposed to, and they've not had any surveillance. Nobody's really sure what's going on. Our workplace exposure limit in the UK is higher than that of many other countries, and I'll talk you through those a little bit in a moment in terms of where we sit in the top the table, really. The regulation and compliance and risk control are still issues. It's not being managed properly. There isn't enough regulation. The compliance is not there because the HSE are so underfunded these days. They're seen as being toothless. They can't do anything. And there's risk control issues because people don't really know or worry too much about what to do to help solve the problem because they don't see it being an issue. So our exposure limits around the world, these are per 8-hour time-weighted average reference period. You go from the worst, which is Poland, which is what ours was until 2006, and then it's us, then the Netherlands at 0.075, down to 0.05 rather for Australia, USA, Finland, Ireland, Italy, Portugal, and most of the EU, to be honest, that publish them. They're in that cohort. And then you've got British Columbia. It's not all of Canada, it's just British Columbia because of the way the country runs. They have different regulatory bodies in different locations. And therefore each one will actually say, that's my province, that's what my regulation is going to be. So theirs, and that's 0.025. So they are the lowest. But as you can see, we're quite high compared to those. What does that mean in real terms? So when you actually look at the evidence of when you start getting lung cancer from silica exposure, you start getting a significantly increased risk at 1.8 milligrams per meters cubed cumulative exposure. So if you think you're looking at 0.1 milligrams a day, I'm not a maths genius, but that's not a very long period of time before cumulatively you've hit that 1.8 milligrams cubed. When you look at the risk, that's the significant increase. To double the risk of lung cancer, it's 6 milligrams per meters cubed is a cumulative exposure. Again, not that much when you compare to 0.1 milligrams. So is our current workplace exposure limit, is that actually low enough? And should it be 0, as asbestos is, or should it be an awful lot lower? Should we perhaps be in line with British Columbia and go down to 0.25? So that was one of the things that came out was, is the well actually low enough? It's still sitting at 0.1 and there's no movement on that at the moment. From the personal perspective, one of the other things we did with this APPG report was we got in touch with a man called Gordon Somerville, who was a stonemason and builder, and he'd worked for many years in this industry. He'd worked with stone, asbestos, and said, well, the asbestos workers had the protection, but the stonemasons didn't get anything. He changed roles various times, and in one particular place, there was exhaust systems in place, but they turned it off at break times and then just dry swept the floor. And if you know anything about how you inhale dust, and also if you've ever swept, your back garden when it's a bit dry, you sweep it up and it's dry sweeping and it just goes straight up into the air in big clouds and you're breathing it all in. But they did have health surveillance in the form of lung function tests in that place. Throughout his career, there was an increasing use of power tools. And the more obviously power you put down, if you're sort of holding a chisel and banging away in a wall, you're creating a little bit of dust, but it's not the same as if you're actually going to take a power tool to a wall and actually take off a layer of concrete off a wall or take off some surface levels. So that started to increase problems. And in the late 1990s, Gordon and his colleagues noticed there were some rumours of this strange illness caused by dust, but most people were oblivious and didn't really think there was any problem. Now, the B&CE APPG report was published last March, and because I've changed jobs, I don't have any contact with Gordon, and I know he was very ill at the time we actually released the report. Wouldn't surprise me to find out he'd actually passed away from silicosis by now. I haven't managed to find anything online about him, but he was always quite a quiet man anyway, and quite private, so it wouldn't surprise me if nothing was out there. He could well be alive, he may well not be, he was very poorly. This was one of my favourite quotes from him. No one ever mentioned that dust was dangerous. Hopefully in this day and age, we know that dust is dangerous, but we're still not really doing anything about it. We're still not actually, saving people and putting things into place to protect people. We're not jumping up and down about it. The Australian perspective, and there was a very, very good SOM webinar on silicosis in September. And since 2018, Australia started to see an increase in silicosis. Predominantly young people with comparatively short exposures. So they weren't people who'd been in the industry for 20 or 30 years. They'd only had 5 or 10 at most years exposure. And there were 3 studies working at the 3,000 to 4,000 people who work in the engineering stone industry in Australia. They screened 1,500 employees, so just under half probably of the total people working in that population. 24% of them had silicosis. and 4% had progressive massive fibrosis. And off the back of that, there was a task force set up to identify the scale of the problem, look at guidance, and also establish a dust registry. Because what they wanted to do was try and look at actually how big is this? This is, you know, we've spoken to around half, and a quarter of them have got silicosis. Is this going to be across the engineered stone, you know, the whole industry? An engineered stone, reminder again, is your kitchen worktops. It's those lovely granite worktops that we have. And the reason it's such an issue within that particular industry is partly because they were making the engineered stone and cutting it without appropriate controls. But also, if you think about your average kitchen fitter, they're not known for their use of appropriate, you know, wet cutting tools or for use of PPE. If you've ever had builders in your house, you know what they're like. And my partner's a builder, so I can say that with, you know, honestly, I know what he's like. Despite my efforts, he doesn't wear PPE very often. But, you know, actually trying to get them to do things properly is quite difficult. So their task force was set up, and there's an update as to what's happened. So in terms of current health surveillance, what the Australian task force is looking into is what actually is happening with that. They haven't published their results yet. I've been watching, they should be out by the end of the year, but they're not out yet. But the concern is that our current health surveillance, certainly in the UK, is probably not fit for purpose. Symptoms and spirometry alone do not diagnose silicosis. And if we do chest x-rays, and to be honest, they're not very often actually done, and sometimes if they are, it's not until 15 years of exposure, they do lack sensitivity. The other thing we have is that because we've, since the coal mines all shut, we no longer have coal workers pneumoconiosis, I never say that one. And because of that, we don't have the radiographers and radiologists now who can actually read and interpret the chest x-rays properly. One thing that the Australian task force has looked at is doing low dose, high resolution CTs instead of chest x-rays. And what they actually find is the chest x-rays show very little change when actually there is quite significant disease, which the CTs do pick up. And their push is to actually stop doing chest x-rays and do the low dose, high resolution CT scans instead. They don't give a massive dose of radiation. It's a little bit more than chest x-rays, but they are far better at identifying early disease when you can potentially do something to actually remove that person from exposure and prolong their life as much as possible. Little bit of case studies as well. This is one from the Brompton, a man in his 50s, a long history of working as a stonemason. Noticed he had shortness of breath, but doesn't recall any health surveillance in his career. He had a chest x-ray and was diagnosed with sarcoidosis and was treated for 2 years. Still at work, still being exposed. And then at that point, somebody thought, he's a stonemason. Could this be silicosis? And sent him off to the Brompton. It was indeed silicosis, and this man is expected to die within 5 years. And this is sadly very, very common. And particularly, as I said, Australia are really noticing this. This is why there's such a push in Australia to actually move forward with improving the situation. We're starting to find that we're getting these people coming through more and more. And until we actually start stopping their exposure and identifying them earlier, they are going to die, because by the time they're getting into people like the Brompton who can recommend what they need to do, and there's not a lot of treatment for silicosis, it's actually about stopping exposure as much as anything. People are going to die prematurely. So our recommendations from the APPG report was that silicosis becomes a RIDDOR reportable condition. Amazingly, it isn't from a silicosis perspective. Obviously, the lung cancer side it is, because it's a lung cancer caused by work, but not for silicosis itself. There was the recommendation of having a targeted awareness program. So actually telling people in these industries that are at risk that they are at risk and what to look out for and what they can do to protect themselves, and really making that quite a hard-hitting awareness campaign. One of the things that we were trying to do at B&CE was that workers were holding their own records when they moved between employers and making sure they've actually got them so they can hold on to those themselves. The difficulty we have with the construction industry, along with a lot of other similar industries, is that people move really quickly from one side to the other, to one employer to the next, and they may have health surveillance, but there's no records, there's no equivalent sharing of information, so you can look at them and go, oh, that's changed significantly from the last time you had a lung function test a year ago. What's actually, what's going on? What might be the problem there? There was also a recognition that we needed some OH support for GP surgeries, because GPs aren't taking occupational histories, and that would allow those to be included in their GP notes and actually be able to help the GPs make the link between what this person was doing at work and what their symptoms were. There was also a big call from a lot of health and safety people, but actually also from some workers and also from some of the unions, for an introduction of respirable crystalline silica regulations, similar to the asbestos regulations, that really bump it up the priority list and make it more of a focus for people. And within that, number 8, looking at actually dropping the workplace exposure limit. There's a need for research into appropriate screening processes, and I think we can learn from the work that's being done in Australia. There's no need to reinvent the wheel. We can learn from what their task force is doing and actually look at our surveillance processes there. Making sure that those industries who generate respirable crystalline silica actually have access to OH, because so many of them don't. The little builders companies, the little one-man bands, making sure they've all got some access to OH as well. Not just the great big, the likes of Kia and Balfour Beatty, the great big companies that do have good OH in place. As I said, reducing the well down with statutory exposure monitoring as well, so that it wasn't just a case of, you know, occasionally doing a little bit of occupational hygiene when you thought about it, but actually proper exposure monitoring regularly, so you know what sort of levels people are being exposed to. Having compulsory control measures and PPE on site with annual inspections of compliance, and to do that it would be a need to increase the HSE resources so they can actually raise their on-site inspections. The HSE don't have the money to be able to go and do the unannounced inspections they used to be able to do. They do go and do a 2-week sort of hit, if you like, on dust in construction, usually in November times, October, November, but people know they're coming. They know when the sort of the hit is going to be, when the real push comes, when that big program is, and they make changes at that stage, which they don't necessarily keep going for the rest of the year. So in terms of the future with silicosis, you know, unfortunately, it's a slow moving beast. And with COVID and Brexit, there's nothing happening anytime soon because the government is just too busy doing other things. But one of the things we need to perhaps look at are exposure assessments. And these are some of the things that were recommended in the Australian task force in terms of what they think needs to be happening. We need to look at complex lung function. So actually not just your bog standard spirometry, but actually doing a really thorough lung function assessment, but also making sure you're comparing past results, and also considering your lower limit of normal. What's acceptable and what isn't acceptable, and what sort of level of deterioration is actually, you know, is to be accepted as normal, and what could potentially be a problem. Those in themselves aren't going to fix the issue. We also need to look at the role of low dose high resolution chest CT scans. I've got my words in the wrong order there. And that's one of the things that we need to look at from the perspective of making sure that we're actually trying to ensure we're identifying cases early. And that will, I think, come. It's just a case of access to CT scanners, but also, you know, how we actually look at a national screening program that doesn't give people too much radiation. And holistic case management, so actually good liaison between occupational health, between primary care, secondary care, and the real high-reg specialists in terms of people like the Brompton, the Gourds group. Because really the alternative is more deaths. And I'm sorry to be a real downer at this time of the evening, but it's true. If we don't actually do something about this now, and it's not just about health and safety, we have a role in occupational health in this as well, of actually pushing through and saying, I think there's a problem here, and referring people across to the Gourds when we need to, because the alternative is that we're going to keep killing our workforce. This is one quote that I found when I was in the middle of doing all my research in that wonderful book I mentioned earlier, and this was a quote from Paracelsus in 1567, who was a mineralogist, and he said, and I'm paraphrasing slightly, but he basically said, we need metals, and therefore we must risk life and health for them. We haven't changed in over 600 years. That's quite scary. We're still mining metals, we're still doing things that put us at risk, and we haven't actually changed them. It's just the acceptance that it's a dangerous job and it's going to kill you. And yeah, is that really okay in 2021? I don't think it is. Thank you for listening. I've got lots of time left for any questions anybody has to have. So if Neil wants to, I'll stop sharing. If Neil wants to open up the chat and have a chat, we can have a discussion generally about where we go from here.
Thank you very much, Pip. Just starting my video. That was brilliant, absolutely brilliant.
Thank you.
I think that certainly I represented IOH at the all-party parliamentary group at the Houses of Parliament, which was, I think that was in March. It
was March 2020. It's forever ago.
Yeah,
it is. And I've actually got the report here. You can download the reports still off the B&C website, even though B&C is pulled out of health. The report is still available. I checked yesterday. It was a fabulous day, and it really felt like there was a move to actually go there. There were a lot of really interested people in the room who wanted to push it forward, and then because of Brexit, it just hasn't gone anywhere. And it's a real shame, because I think, you know, we haven't got long to try and fix this. We've known about it for over 2,000 years. It's really about time we actually started doing something about it.
Yeah. Yeah, absolutely. There was a lot of interest, and I think that you know, from the people in the room, it sounded as though there was going to be a lot more action than has actually happened since that time.
It did.
You know, from that point of view, it's I suppose it's slightly disappointing. But I think at the same time, we have to remember that there's been a pandemic, which, you know, hasn't helped anything change really in terms of, you know, legislation. You know, it's hard enough to get things through Parliament now. And I think, you know, the momentum on health is still very much surrounding COVID-19, isn't it?
It is very much so.
And I think that's likely to be the case for the foreseeable future, because obviously, you know, health and the health professions are extremely short-staffed, and the time that they have got available is probably not going to be put into such things as silicosis, is it? Which is it's not.
It is, because it's one of those things that we've had this, we're still fighting over 3,500 deaths a year from asbestos, and we've had regulations since the 30s and 40s with the original ones, and they've obviously ramped up over the years, and we don't have anything like that for silicosis. And my concern is we're going to start having 3,000, 4,000, 5,000 people dying a year, because we've got a lot of people working in the industries where they're exposed. It's predominantly the construction and the trade industries. But even, you know, it's people who work on the streets in civil engineering, it's people who are in demolition. There's lots of different exposures. And the other thing with demolition is where I live in the southeast, and one of the estates near me, they build the business estates. They're doing an awful lot of demolition of buildings and putting up flats. And there's already a lot of flats in that area. And when you go past, they're demolishing buildings and crushing concrete. There's clouds going into the air, and it's similar to, we'll get teachers, as we have now, who have asbestos from exposure in schools, and you wouldn't think them to be in an asbestos exposed profession. We're going to have people just who are walking through those clouds of dust day after day, and particularly in London with the amount of construction that's going on. It's the same thing. We're walking, you know, you're at risk as a just somebody walking down the street. Yeah.
That's pretty much true of asbestos and the NHS as well, because the NHS buildings are full of asbestos.
Absolutely. Yeah.
And there are still a number of NHS workers that are diagnosed with asbestosis on a regular basis. You know, so we mustn't underestimate that. And that's, you know, they're not working with asbestos, they're just working in an area you know, where there is lots of asbestos and lots of maintenance going on, and lots of buildings still haven't been, you know, had all their asbestos identified, because they've not been able to, you know, to get into some of those spaces.
No, absolutely.
So I think that that problem isn't going to go away.
No, I don't think it will. You're absolutely right, and it is a real. It's a real challenge for us, but I think if we had some regs at least and had an idea of who was actually being exposed, we'd probably have more of a handle on the problem to actually know how we're going to fix it, because that's the starting point, is knowing exactly what the scale of the problem is. Yeah,
absolutely. So let's open up the floor to any questions. Has anybody got any questions for Pip?
I don't have any questions, but just a comment, because if this is what's happening in our country, where we're actually a very first world country, then what's it like out there in all of those very third world countries?
I dread to think, Janet, I dread to think. You're absolutely right. I mean, you know, Australia is probably leading the way in terms of the task force they've got going and trying to get things fixed there, and I hope we'll learn from their experiences. But you're absolutely right. All over the third world, where they've got people, you know, demolishing buildings, building new ones. There's no controls, there's no exposure limits, there's no PPE. There's going to be more issues there as well. It's a worldwide problem. Again, we don't know what the scale of that problem is even here, never mind anywhere else. It's hidden very much so, and it's very underdiagnosed. People don't really know what it is, so they don't think, and because they don't know they're exposed to RCS, if they start having breathing problems, they don't go to their doctor and say, it might be silicosis, I work with RCS. And if they did, no disrespect to GPs, would the GP know what RCS was? Probably not. It's one of those things that people aren't aware of, and that's what was coming through from the report when we spoke to the specialists, the doctors. They were actually saying they don't get occupational histories, they have to do it themselves, and that's where having OH in GP surgery to help support that would really help them, not just for these workers, but for everybody. Actually taking an occupational history is quite a skill. and it's rarely done, and it's certainly not done well.
No, absolutely. One of the questions I've got, Pip, I mean, obviously, working in the NHS, I didn't do any health surveillance for maintenance workers because that wasn't a consideration. But obviously, quite a lot of people do still require health surveillance. What are the questions? Are they the standard questions that you would find on any health surveillance?
Well, they are, but they don't really, because the problem we've got with silicosis is by the time you actually have symptoms where you would notice them, or you have a deterioration in your lung function, it's really too late to do anything. You've missed the boat. And this is where the high resolution CT scans come in, of actually scanning people regularly to see if they've got any changes before they have symptoms. Because by the time they get into the Brompton, and actually, like that poor gentleman in his 50s, expected to die within a few years, because actually it's too late. You've got to the point where they've got progressive massive fibrosis. I mean, 4% of the people in the Australian task force cohort they looked at had PMF, and they were all people that had only been working in it a few years. A lot of them were in their 30s. It's quite scary reading. And in terms of what you would ask, yes, it's the usual. Have there been any changes? Are they worse when you're at work? But it's shortness of breath, it's cough. But again, they're all things that might happen when you've already got irreversible disease. Yeah.
And then an observation then, based on that, is really, I suppose, that if we're going to be, if employers have got to pay for high resolution CT scans, it would be better money spent on eliminating the risk in the first place, wouldn't it? Because
absolutely,
that's probably likely to cost less
than all those scans.
If you've got a workforce of 30 people that are making your travertine worktops and what have you, or you may have hundreds working in a construction site. You would be better to actually consider investing in tools that do wet cut.
Absolutely, and using them, maintaining them.
Yeah, absolutely. So I think that that there is hope if, I suppose, the size of the problem is actually realised and acted upon.
Yeah, I'm just flicking through the report because there is a wonderful quote in here, and the quote was actually from Robert Bradford of Bam Nuttall, who's their health and safety manager, I believe. And he actually said the use of health surveillance is akin to putting a sticking plaster on a cut. The damage has already occurred, and he's absolutely right. Health surveillance is while we still have to do it, we should be aiming for a world where we don't have any health surveillance because we've fixed the problem. Because, like you say, we've got the controls in place that actually remove everything.
Yeah, I mean, I think that I was quite astounded in one of the lectures that I did at the University of Derby this week. I'm not going to say to what group, but nobody in the room had heard of the hierarchy of control. And whilst some of the students were new to occupational health and had never worked in occupational health where it might be excusable, there were some that had quite a lot of years of experience of working in occupational health, and that astounded me. And it was like,
it's one of those things. I think the overlap. Yeah, the overlap between occupational health and health and safety is really important. And I think we sometimes go, oh, that's a health and safety issue, and brush it away. But actually, it's not. It's a joint responsibility. There's such an overlap, and I'm not surprised. I put the pyramid up in front of a group of one of the national, I won't name them, one of the national construction companies have an annual sort of study day, if you like, to talk to all their contractors that work for them, and they get people from all their contractors, and I put that up and they were like, well, that's really good, where did you get that from? The HSE website, every health and safety publication ever. It's really common, and I was gobsmacked. The people working in the industry didn't know what it was, so it doesn't surprise me that the nurses don't, but it is quite scary.
Yeah, it is. That is going to be mentioned as one of the domains, I believe, in the new Skiffen standard.
Excellent, good. So that's really important.
Which is really important. Right, so has anybody else got any questions?
Steve popped one into the chat. So do we have any idea of the numbers workers exposed in the UK? No. because we don't have an idea of the size of even the construction industry. There's about 37,000 people in the construction industry, probably more, because there's an awful lot of people coming in and out of it. How many of those are exposed to RCS, we don't know, because there's no register, and absolutely a register of workers employers would help, because at least we'd have an idea of the scale of the issue there. And it's something very much that Unite were trying to do. They've got a silica register, but it's voluntary. It needs to be mandatory, because if we don't get, we actually don't get a mandatory register, we're not going to get anywhere.
Ah, wonderful.
Yes, I've heard that, Janet. I haven't heard any more than that, but I think it'll be really interesting. And I know certainly with the work that is going on in Australia, I can't remember the name of the gentleman who gave the slides, but it's in the references on the PowerPoint, which I'm quite happy to share. He was actually talking about what they're doing in Australia and how they're pushing it through. And I think once that comes through, I'm hopeful that the UK construction industry and the UK medical boards and GORDs and people like that will start to really push for things to happen in this country as well.
One thing, we work with EKFB, one of the joint ventures on the HS2 project, and what they've decided to do is, because you were talking about all the little, all the small, companies out there, because of course they don't even bother with it. No. But sometimes those big companies can actually really force the little companies to do something about it, and that's what the EKFB are doing as a joint venture. They're actually making all of the smaller contractors are actually in their own health surveillance program, and they're making sure that they're within that, which I think is really good. But then we work with another one where they don't do that. So yeah, but it would be good if any of those big projects, if they're mandated, will actually
absolutely we'll pull them in and make them do it, because it will then start to get people, we actually get a handle on the idea of how big the problem is there, because we don't really have that at the moment at all.
Okay, so if there are no further questions, I'd like to thank you very much, Pip.
Thank you.
Once again. That was really very interesting, and certainly something that we all ought to be watching this space on. So again, on behalf of IOH and your fellow board members, thank you very much.
Thank you.
Thanks, Pip.
Excellent. Thanks.